Good evening, all. I welcome you all on behalf of ACE for today's webinar on revitrification. So, this is very interesting topic. I think we all are doing in our lab regular vitrification. Sometimes we definitely do revitrification of the embryos because of certain reasons, and maybe for cryopooling, for PGS, or maybe because the patient is having some issues and we are not able to transfer the embryos. So there are certain reasons where we do revitrification. There are certain papers which support revitrification, and they tell that okay, the results are more or less same. But yes, there are certain publications which are recommending that you should not be doing revitrification because it is affecting the pregnancy rate, implantation rate, and even the live birth. So today's webinar is focused on revitrification. So I would like to introduce my chairpersons today. Arti, can I have the slide, please?
Aarti, please share the slides.
1 second, ma'am, I'm doing.
So chairpersons for today's webinar are Dr. Prabhakar Singh. Next slide, please. Next slide, please.
Aarti, shall I start screen sharing?
You can start from your end if you
Okay,
have
fine.
it access.
Yeah, I'll be doing. Is it visible?
Yeah, it's visible.
So, yeah, Dr. Prabhakar Singh's slide is there. Devan bhai,
Yeah.
you can.
So our first chairperson is Dr. Prabhakar Singh, who is scientific director at Nimaya Women's Hospital. Our second chairperson is Dr. Harsha Bhadarka, who is working at Akanksha Hospital in Gujarat, Anand. The third chairperson is Dr. Ramesh Raja. Yeah. So he is a senior consultant, clinical embryologist, who is working at Nakshatra IVF and Women's Center. Now I would request one of the chairperson to introduce the speaker, the first speaker.
Dr. Ramesh, Dr. Harsha.
Hello, Vanakkam, everyone. It's my pleasure to introduce Dr. Sandeep Karunagaran. So he's a reproductive specialist and embryologist. He's a medical director of oval fertility from Hyderabad. So we know him for his academic work, and it's my pleasure to be introducing him. And we are waiting to listen from you, sir. And this is for you, sir.
I'm stopping sharing.
Thank you, chairpersons, for the introduction. I'll just share my screen. Is it visible?
No, sir.
Not yet.
How about now?
Yes. But we can't see your presentation.
One sec. It's a very interesting topic for a simple reason that, I mean, when I actually started working on this, I realized that there is no, I don't know where my PPT has gone. One sec. Even this happens, I didn't realize. Okay, that's where. Yeah. Okay.
Sir, we need to do full screen.
I'm getting to it. Thanks.
Yeah.
Okay.
It's visible now. Yeah.
Okay. Just assume that it's Saturday evening and on Sunday you're expecting a huge load of guests. You prepare a wonderful pudding, and it's puddings, as you know, can be prepared one day in advance. You put in the refrigerator. On Sunday, unfortunately, only a few of them arrive. You open the refrigerator, get the pudding out. You serve it to the host. Obviously, what is meant for 12 people can't be eaten by 6. So a lot of it is left behind. What do? You put it back into the refrigerator. Same thing can be done with embryos, and that is exactly what I'm going to talk about today evening. So, can we actually preserve the embryos for the future or for future use by revitrification? That is exactly what I'm going to talk. Thank you, Ace, for inviting me for this challenging talk, because when I actually checked out the entire thing, went to the literature, my co-speaker, Dr. Sarguna Devi, she has a lot of articles, and I realized that I don't really have any articles to lean back on as to how, when, and why to do revitrification, and what are the practical strategies that will give a better income. Needless to say, I don't have any disclosures, no commercial interest. My talk is going to be more clinically inclined, as well as embryology, of course. But most of what I'm going to say is from my experience and experiences of my friends who I've tried to put down in these few slides which follow. So, what is revitrification? It's a very simple thing. It is the process of it's process of warming a previously vitrified embryo and then vitrifying it for the second time. Now, most of the times, this decision to revitrify initially was considered as a last resort when the immediate clinical program or procedure which was planned could not proceed for one reason or the other. The primary concerns earlier, at least definitely in the last decade or so, was possibly the survival rate wouldn't be as much as one would have with the fresh vitrification, or there could be decreased viability of the embryo that we have in our hand. So that is the reason why historically revitrification never actually saw the light of the day. It's only very recently when some inadvertent incidents where people were forced to freeze the frozen embryo again, the people realized that no, I mean, it can actually give pregnancies even when you revitrify. So one should remember still that it is not a routine procedure, but slowly and surely it is entering our toolkit. So let's, without wasting much time, let's see why should we do revitrification and what are the possible clinical scenarios that actually entail us to do this procedure. So I've tried to divide the indications into three parts. One is clinical, that is what is related to the patient mainly. One is lab indications, that is related to the embryo or the oocytes. Or if there's a multi-specimen management indication, that is, it could be a time where there are a lot of things which play in together to give a situation where revitrification is mandated. So let's talk of the patient factors first. We know that it takes it's the 6th day that we do the transfer after the progesterone is started. What happens in these 5 days? What happens if a person develops fever? What happens if the person has a GI infection or suddenly a need of surgery? Appendicitis happens. And it happens on the day the embryo transfer is done or the previous night. The patient or the couple hasn't had the time to inform us as to what needs to be, I mean, that they will be not available. The embryologist in the morning has thawed the embryo, and then what do we do next? I had a case where the patient actually, on the way to the hospital, met with an accident and had to be taken into emergency for surgery. So, I mean, that was one of the first times that we decided to revitrify because the patient said we are leaving home and they never reached the hospital. So, all these unexpected maternal illness could be one of the reasons that we would want to revitrify. There could be endometrial reasons, uterine reasons. For example, I mean, I do a scan on the day prior to transfer just to see if there's something else, or if there are many times, we work on this hub and spoke model. The spoke doctor has actually referred the patient to the hub, and the doctor who's actually going to do the transfer wants to do a scan. You see, the endometrial thickness isn't good. Or there is suddenly appearance of fluid in the cavity. That is, there is a hydrosalpinx flare-up. Or for some reason, on the day that the patient has walked in for the embryo transfer, she has had an episode of bleeding in the morning, which makes you puts you onto very unstable grounds. You really don't know what to do. Possibly revitrification is the answer. Or, for example, on the day of transfer, after thawing, on a casual talk, this is again what I always do before a transfer is done, to ensure verbally that the patient has taken medicines properly in the correct doses. What if the patient has failed to follow your instructions properly? So, if the embryos have been actually warmed, then we need to put them back into the freezer. Now, let's talk about factors which are beyond our control at times in the hands of the oocyte or the embryo. For example, you warm an embryo on day 5 or day 6, I mean on day 5 obviously, and it fails to re-expand. You thaw the next embryo in order to suit the timing of the clinic, because you know that once you thaw an embryo, it doesn't expand, the patient has spare, you thaw the second embryo, you transfer the second embryo, you come back to see the embryo later after the transfer, it could be the same day or the next day, and you see it has expanded. Can you throw that embryo off? Obviously not, especially if it's a good one, because obviously you decided to warm it because it was a good embryo. So this again can obviously be one of the reasons for revitrification, that is failure to expand. Or for matter, you do, there are some clinics which practice assisted hatching routinely. You hatch an embryo, it doesn't pass through the hole that was created. Why it did not? Possibly the embryo was not strong enough, viable enough, or competent enough to pass through that small hole. What do? You thaw another embryo, you hatch it, that works. You possibly have to refreeze this one because it hatched later than the first one hatched later than the second one. Or if there's a sudden change in therapy, this is one of the most common things. A patient comes in for IVF, goes through day 5. They say, yes, we'll freeze the embryos. And later they decide they want PGT on the embryos. Or they do PGT on, let's say, 2 out of the 5 embryos and both come aneuploid. So what do? The other 3 embryos are still in the freezer. So at times, PGT itself is an indication to do a revitrification. That is, a frozen embryo has to be warmed and biopsied and then revitrified. The second thing is when the previous biopsy has yielded no cells or insufficient cells, or a genetic analysis is not forthcoming. Then possibly you have to rebiopsy the frozen embryo already, and the already frozen embryo. Another reason is a multi-specimen management indication. For example, to save space, or possibly done about 3-4 years back, because nowadays people come back for the second embryo transfer after about 4-5 years also. You have frozen on those days, which was the rule or dictum at that point in time, to freeze more than one embryo on one straw, one blastocyst on one straw. You thaw that. You have, for example, you have 3 embryos on one straw. You thaw that, you realize all 3 have warmed very good. Since the parents have already one child, you don't want to give them twins now. So you have to freeze the already the embryos which are surplus. So this again forms a very important reason to revitrify the specimens. Now let's talk about what are the steps that are required to do in this entire process of revitrification. Of course, needless to say, I would like to remind the house that what I'm going to say is absolutely from my experience and little wisdom that I have. So please forgive me or add on to the knowledge if I miss some steps. First, the most important thing is assess the need. Do you really need to revitrify the already frozen embryo? Remind the house. Second step is possibly going to thaw the embryo and grade it. Experience. I'm immediately on thawing. Little wisdom that I have. Let the embryo recover. Let it re-expand. Forgive me or add on to the. Then, if you have a cohort of embryos, select the embryo and counsel the patient. Selection here, what I mean is to select the embryo that you really want to revitrify, not select the embryo that you want to transfer. Then vitrify and then document it accordingly. I'll be talking about all these steps in a bit of detail, and the rest is left to the intelligence of the house to accept what is correct or what is most suitable for them. The first thing that you obviously must do is to list the situation that you would or your clinic would want to re-vitrify, make an SOP. See if the current situation actually fits into the SOP. And what is more important is counseling of the couple. Communicate what you're doing, document this communication, and save this communication. Because if you miss any of these steps, believe me, you are going to land in court. So once you thaw, thawing is obviously done as per SOP or protocol, and best done by the most experienced person. Ensure expansion, weight and grade. If it is a thaw to extend, that is, you do a day 3 thaw and cultural blastocysts, you have to grade at the appropriate time.
Sila una. Sila
If,
sang make
if,
webinar.
if it's a day 5 thaw, wait for complete recovery. Make sure the expansion is complete before you grade the embryo and grade at the correct time. Also, what is more important or what is to be noted is the time between the thaw and the grading, and you must fit the hours of development of the embryo as per the protocol. One second. Can the admin actually admit all the people, because it is disturbing me? Yeah. Okay. So after you have, after the cohort has been thawed, you can differentiate the embryos according to grade and select the ones for the transfer or biopsy and do the required procedure. Identify the embryos which need to be re-vitrified. Re-allot the grading of the embryos. That is, once you've decided that, let's say A, B, C, D are there, you have transferred B, A, C, and D need to be re-vitrified. So you have to allot a grading to that. And again, the process of counseling is required. Why is this required? You have to tell the patient, actually give a objective score to what is the success rate if you transfer the same embryos. Needless to say, after that, you follow the process of vitrification. Ensure new cryo devices are used and store the device in the correct place. That's called taxonomy. And obviously, document everything. So revitrification is essentially a repeat of the original process. That is, I mean, I'll not go into the process of vitrification again and again, but revitrification is essentially the same thing. So I'll just run through the steps. I mean, one has to prepare solution, transfer to the holding medium. Obviously, you have to have a timing check. The first step is obviously transferring on to an equilibration media, incubate it for the set time as per the protocol written in the product insert or according to your clinic protocol. Transfer it into the vitrification solution. Obviously, here we all know that the time period here is very, very critical. It has to be very short, specific, to achieve maximum dehydration, but without sustaining chemical toxicity because of the high CPAs which are concentrated in the cell within the cell. Okay, loading of the device is also equally important. You ought to load with a minimal amount of vitrification solution. You have to seal or lock the cryolock in the correct position and plunge it into liquid nitrogen as is said by the protocol. We know once loaded, it has to be directly plunged into liquid nitrogen and it has to be stored, and the storing has to be at the correct place, labeled properly, and it can be indefinitely held till the next planned warming and transfer cycle. What is most important is documentation of this entire thing. We have to note exactly where the new placement is done. Also, it is best to connect everything, that is the OPO cycle, the past placement, and the current placement where it is kept. Also, enter the reasons of revitrification in the remarks column or in your EMR, whatever actually is being followed. The fundamental principle of revitrification happens to be the same, but all of us should be aware that this set of cells have already undergone one chemical exposure and osmotic stress. And potentially when you expose them to the next one, it could be more fragile and it could be more dangerous. So what are the practical tips that I have actually gathered or harnessed for improving this revitrification process? Obviously, stringent quality control and protocol adjustments go hand in hand. It must be mandated. So I have tried to divide the steps into these three, that is specimen selection and quality control, protocol adjustment, and some ways of minimizing stress. and the platform and technique optimization. So the specimen selection and quality control would mean that you select only the high quality and intact specimens. Don't vitrify poor quality embryos. So embryo grade must be noted, whether be it day 5 or day 3. Obviously day 3 I have not revitrified, but day 5 obviously we have to revitrify at many a times. Make sure that the morphological integrity of the embryo is perfect. There should be no cell lysis or minimal cell lysis, and it should have clear and healthy cell morphology. If the blastocyst is not expanded completely, you must note it down and possibly revitrify it at a slightly later time rather than the routine time that you would want to do it. If at all one has vitrified more than one embryos and you have selected one embryo to transfer and the rest to be revitrified, make sure the time gap between the freezing, the warming, expansion, and the revitrification is as less as possible. The less amount of time spent in the culture media would mean less amount of stress to the embryo, and that is how it would be giving us better results. Also, this is a food for thought. Would ultra rapid vitrification be helpful in these cases? Because embryo which has already been exposed to a lot of cryoprotectants, would ultra short or rapid revitrification, that what we generally call as fast and furious, be helpful in these cases? Thought for all of us, which means that when you do ultra rapid vitrification, it would mean reduce incubation time to both ES and the vitrification solution. Obviously, when you are revitrifying, the solution should be strictly as per protocol as mentioned in the product insert. Any deviation can alter the kinetics of the water movement and the CPA penetration, which would mean that there would be increased chances of intracellular ice formation. Another small tip which I always propagate is to use low volume vitrification devices. Obviously, we all know that the minimal amount of vitrification solution which is present on the straw would mean better heat transfer, and it would ensure that the heating rates are better and the warming rates are, the cooling rates are better and the warming rates can also be easily passed on without the fluid which is present between the embryo and the liquid nitrogen. Possibly the most important thing is we consider vitrification as the job of the junior most embryologist, or the person who's just is metamorphosing from the junior embryologist to the mid-level embryologist. But remember, when it's a case of revitrification, I personally feel the senior most embryologist should be taking this on as a challenge, because even a small change in size of the droplet while vitrifying would mean increased risk to the embryo that it is going to hold. The ideal, obviously, we all know that should be almost invisible film of solution surrounding the embryo. Another thing is, once the plunging is to be done, when the plunging is to be done, it has to be done almost immediately, so that the transfer of heat is between the embryo and the liquid nitrogen is as fast as possible. And this is again a very stringently controlled step, and this needs to be done with the hands that are the best in the lab at that point in time. That is the senior most embryologist who is available for at that time. So when you think of this entire process, there are two important things that I would definitely want to put across. Only revitrify high-graded viable embryos. And please do not revitrify a bad embryo, because that actually locks in hope for the couple, wherein a lot of hopes, a lot of anxiety will be given to the couple. And with the background, what do I say, for lack of a better word, belief that there is someone waiting for you in the cryo tank. Again, as I said, the strategy, the human factor, use the senior most embryologist available, and possibly a non-human factor in this, or the non-lab factor, is patient counseling and consent. Make sure the consent clearly says that the survival rates are going to be lesser than the first vitrification. To end, we all know revitrification is becoming safer and safer as more and more people are doing it. But still, please don't consider it as a routine procedure wherein you can, delegate it to the junior most people. It will somehow and slowly become an essential part of PGTA. especially if people are don't have the finances to do PGT of all the embryos which are present in the first time. They could freeze now and do a thaw biopsy vitrifying later. And remember that in revitrification or complicated procedures, it is not luck that matters. It is protocol which actually gives you success. So use strict embryo selection and use the senior most embryologist. I have to revisit these points again and again because it's absolutely necessary to put it across. Needless to say, documentation is of prime importance. If you don't want to visit a court, please ensure that counseling is proper, counseling is documented, counseling is communicated and stored in the proper way. And most important, I feel, is transparency. You have to tell the patient what is the, give an objective number to the success rate of the embryo which has been vitrified for the second time. With this, I end my talk. And also a small invite that self and Dr. Alex Verghese are doing a small conference at IIT Hyderabad between 24th and 26th of January. And I would solicit all your presence out there to make this a successful event. We are calling about 8 to 10 foreign speakers. And it is also what is important is we are doing a workshop for entrepreneurship. That is possibly the first time in the country that we are doing it. We will be having a business workshop also there. Thank you. I am open to questions. Thanks a lot.
Question and answers we'll be taking in open forum. So please be with us and let us continue with the second talk. Because open forum we have meant for this purpose only. So may I share my screen now?
Yeah.
Manisha, I think Dr. Sarguna Devi is still coming in. So maybe
Okay.
if there are a couple of questions till then,
Perfect.
has she come?
All yours, sir. So if there are any questions from the audience, we are ready to take up.
So I would like to ask one question. Dr. Sandeep?
Yeah, I'm here, ma'am.
Yeah, good evening. It was an excellent talk. But in your experience, what do you think would be the major risk of revitrification? In the sense, would you like to throw some light on whether it is the zona hardening, the mitochondrial dysfunction, or maybe the sublethal DNA damage? What are we looking at? Do you have
I
any
think,
insight?
Sonal ma'am, it will be a combination of everything.
Yeah.
So, 2 episodes of microscopic intracellular ice crystals would possibly add up. 2 episodes of exposure to cryoprotectants might definitely harden the zona more than one exposure. So I believe it is not a single factor which actually causes the harm. It is the same insult the embryo has to bear the insult twice rather than once, which actually, what do I say? It propagates the situation or damages the situation even more.
Yeah. So, in your experience, if you have a revitrified blastocyst, because you mentioned about zona hardening as well, would you, wait for it to go into the hatching stage before you would
I
like to
would go,
transfer this embryo?
So if I feel that there is a element of zona hardening, that is, especially when you do pipetting, you will realize that sometimes the zona is not as pliable. I'm not a big fan of zona, hatching. I'm a big fan of zona thinning nowadays. So I don't, make a complete hole. I just thin it up to around 25% or so, and then let the embryo do the rest. Because until then, unless the embryo actually expands, it doesn't show expand to its full potential. You make it so there are or possibly I have not done a study on this, but I have found out in my whatever limited experience that the implantation rate is better in a zona thinned embryo as compared to a completely assisted hatched embryo.
And would you also happen to make any changes in your pipette diameter in case of revitrifying the embryo? Because the pipette,
Not really.
not really. Okay.
Unless it's hatched completely, or it's half of it is outside already, then it's a different thing. Especially this will happen in the biopsied embryos, which have been revitrified.
Thank you so
this-
much.
Sir, it was a very comprehensive and excellent talk. There is a question from the audience from Dr. Mrali Patil. She wanted to know how to identify a viable embryo after revitrification and rethawing.
Oh, the signs of viability remains the same. It has to show expansion. It has to show some signs of life. Sometimes I feel, day 3 at least had a time to divide and show us. Unfortunately, when it comes to day 5, there is no other way but expansion. So there has to be some change in the shape and size of the embryo to exhibit viability. That is why, lot of there's two schools of thought. I mean, all of you are senior people. You know that some people transfer the embryo directly after thawing, but I somehow prefer that, I wait for some time, see some sort of expansion, see some cell changes, and then do the transfer, be it the first vitrification, thawing, or the second thawing.
Thank you so much, sir.
Thank you.
So can I have just a minute, Manisha?
Yeah.
Do you have any experience or any publication you went through that you have any idea of epigenetic changes in embryo after rethawing?
I have gone through a lot of literature, but Sarguna will be talking about the literature search and the research articles because she got the better half of the deal. I was doing the how, when, why, indications, what to do. So that is where my scope of things are. I think Sarguna will be in a better position to answer that question. But we all know that the more time the embryo is exposed to an alien environment, that is our incubators, our culture media, vitrification solution, thawing solution, again vitrification solution, and again thawing solution, there are definitely increased chances of epigenetic changes. I don't remember reading across any paper wherein they have actually quantified this change.
Thank you, sir.
So thank you so much, sir. And now it is time for our second talk. Chairpersons, could you please introduce our next speaker, Dr. Sharguna Devi?
Yes, our next speaker is Dr. Sarguna Devi, and she is Director of Embryology and Academics, Dr. Advin's IVF, and she is Executive Committee member of ACE India and Coordinator in MSc Clinical Embryology in Crescent University, visiting faculty of Aspire, IARS, and Mysore University. Over to you, Sarguna.
Thank you so much. So I'll share my screen, yeah. Is it visible?
Yes, it is visible.
Just make it full screen.
Fine. Okay, very good evening to everyone. Thanks for the opportunity. I'm not going to take longer. So I'm going straight on to the literature evidence on the survival, implantation, and live birth rates after embryo revitrification. So as we all know, ice crystal formation is the most significant source of cell damage, but it can be completely eliminated by vitrification. There are various parameters behind a successful vitrification, like cooling rate, warming rate, whatever. But vitrification itself is having a minimal negative influence on viability as per the reports. Is it very similar with double vitrification or revitrification? This is the question left with us today. And I'm going to try and find some evidence from the reports we have. As an overview, I'm going to connect with some case reports, which were reporting the pregnancy and live birth in each case as a first report, added with some larger reports as a systematic review and meta-analysis on this context. So sir might have covered everything. So these articles, whatever I am going to quote, have been already covering everything, like oocyte vitrification to embryo development and transfer and results. The revitrification is done for the sake of cancellation of transfers, medical reasons, and biopsy. So first ever reports. So I couldn't resist myself adding this slide because this was the first ever report from oocyte cryopreservation by slow freezing, actually from 1984 from Australia. Christopher Chen, he had a single solution of DMSO, and he has taken the oocytes, trimmed the cumulus cells, and he went on with a slow cooling of between -7 and 36. And then he did a flash freeze onto the liquid nitrogen. Warming was quite simple. He warmed them with a 37 degrees Celsius water bath. So this has been reported about 40 years ago. It's huge, like a long time, I would say. Today, it's much simplified and sophisticated for all of us with the advent of vitrification. So talking about the first live birth from oocyte vitrification. So when was it reported? 15 years after Chen's report on oocyte cryopreservation from Australia, again from the Monash team. So 47 years old oocyte recipient, she had an ICSI with frozen, means vitrified oocytes from the donor. And the embryos were subjected for PGT, for euploid transfer, and a healthy female baby was reported. That was the very first report from vitrification. What about the blastocyst vitrification? Then in 2004, a Japanese team has reported from a self-stimulated cycle. This 31-year-old woman had a failed sequential transfer. So in the first cycle, she had 2 day 3 embryos transferred and a day 5 embryo. So there was a sequential fresh transfer, which was failed. And the rest of the embryos been cultured to day 6 blastocyst and frozen. There was one zona-free embryo frozen. And in later, on a frozen embryo transfer cycle, they have thawed the vitrified zona-free day 6 blastocyst, and the pregnancy has been confirmed. It's been reported. So this author has done a lot of work on day 6 and day 7. He's so fond of that. Probably this started from here. So revitrification or double vitrification. What was the very first report we have is from 2011 from USA. So Chang et al., they have reported 2 successful pregnancies at the same time. And they had 2 patients per donor oocyte program. The donor oocytes been vitrified and warmed. ICSI was the insemination technique, and blastocyst culture and a fresh transfer ended up with no pregnancy for both of them. And later on FAT, they have had vitrified blastocyst transferred, and they had an ongoing pregnancy by the time they have reported this. So this suggests that human oocytes retain their developmental competency, and any additional procedure like a revitrification procedure may not block their potential to implant and develop as a baby. So what about double vitrification and biopsy, with biopsy? Is there any reports? The first report was from the USA, Peng et al. And that was for 28-year-old woman. And the PGT was performed for family balancing from frozen day 2 embryos, thawed, cultured to blastocyst, biopsied, revitrified, and an euploid embryo resulted in a healthy live birth. This was the very first reports. So these ones have been the case reports where they have just taken 1 or 2 cases max to report. So what about the larger studies? Later, we have had a lot of studies coming up, and the individual studies have been, as always, like they've been saying, like may have an impact onto the outcomes or may not have an impact. They have analyzed every part, like different vitrification, different biopsy procedures, combinations, slow freeze versus vitrification, all have been covered in many of the systematic reviews and their meta-analysis. So let us get on with a few updates so that it's not much boring for you. So this one from Kobo et al. From 2014 is one of the significant studies on revitrification of embryos and their impact onto the clinical outcome. So this was a retrospective cohort study, and it included donated and autologous cycles, cyst transfer, single embryo transfer, double embryo transfer. So they had 2 groups. First group, the test group was vitrified oocytes, thawed, embryos created, revitrified and transferred. And the control group had fresh oocytes inseminated or injected, and they have had the vitrified embryos transferred on a later stage at the transfer. So here I found something was very interesting. The self-cycle women's, the mean age of them was 37 years, and the recipients were 42 years. So they're quite old, that I was thinking. So this was working for them means it's like maybe can be applied to the gold standard patients also. So the finding of their analysis was the survival rates, implantation and pregnancy rates, live birth rates, as well as the delivery rates remain comparable to those of embryos from fresh oocytes, means the embryos derived from the fresh oocytes. So this is the very first report with a larger number of cryotransfers of vitrified embryos generated from previously vitrified oocytes. So here they have suggesting that the capacity of the embryos to sustain any additional vitrification process is healthy, and they can lead up to an implantation and live birth. So next one is the systematic review and meta-analysis. So what do they study? Because there are plenty of reports are available for re-vitrification and re-biopsy, whatever we are going to discuss. So I have taken a few from 2023, 24, and 25, so that we are just having very recent systematic review and their analysis. So this one is from 2023. They have compared single versus double cryopreservation. And good number of ET cycles being performed from 14 studies being taken into consideration for analysis. And all they have found was, before that I need to tell you, like the slow freezing and then vitrified and vitrified. So all the combinations were available here. So what they found, significant reduction in embryo survival and CPR in the slow freezing group. And live birth rate of re-vitrified embryos were also notably affected. So overall, a decreased live birth rate and an increased miscarriage rates observed between them. And no significant difference was found in the neonatal outcomes. So what they were trying to imply was re-vitrification can lead to impaired embryo viability and a lower rate of IVF success. But the neonatal outcomes can remain comparable with another group, test group, the control group. So this is from Serio, from Switzerland, Lausanne. He's an Italian. We see him quite often here. So this is about review on vitrification, and there is a part for double vitrification as well. So I discovered a very interesting study, so I thought I would just take it for presentation. Again, here it's a single versus double vitrification have been compared. And what they found was like there is a decreased live birth rate, but neonatal outcomes, again, there was no significant difference found between the groups. So talking about the birth weights, so the percentage of preterm birth weight, low birth weight, large for gestational age, and macrosomia were not significantly different between the single vitrification and double vitrification patients. So what they suggest is the process may impair embryo viability, but we should maintain a cautious attitude towards the re-vitrification, double vitrification. So what about the combination of re-vitrification and biopsy and rebiopsy? So what do the reports tell us? So this is like a single study, it's not a review. This is from Taylor et al. From 2024, and they had taken two groups, cryopreserved blastocysts by vitrification and subsequently biopsy, that's all. So this is group one, and other group is having every type of cryopreservation and biopsy combinations. So double vitrification, single biopsy, slow vitrification and vitrification, vitrification and re-vitrification, also double vitrification and double biopsies, all groups being taken as the test group. Ideally, they found no significant difference between the implantation, clinical pregnancy, or the live birth rate between the groups. So this author has been suggesting cryopreserved blastocysts by vitrification can be successfully thawed, warmed, biopsied, re-vitrified, and rewarmed. It's an individual report, just to say a positive note on this. But when it comes to systematic review and meta-analysis from 2024, last year, from Petrone et al., this was like presented in ISHRE, Amsterdam last year. And they have retrieved a lot of studies, because 3357 studies, you see how many numbers of reports being out. Only 7 studies they could include and consider for meta-analysis. So again, they had all groups, single biopsy with double vitrification, and single biopsy with single vitrification, also double biopsy with double vitrification. So all sort of comparisons were there. So all they found, single biopsy with double vitrification was having significantly higher miscarriage rate and compared with the single combination. So the clinical pregnancy rate as well as the live birth rate were instead comparable. So only increased miscarriage rate, nothing else they have seen. With the double set, there was a lower clinical pregnancy rate as well as the live birth rate with a higher incidence of miscarriages when comparing the single group. So which means this is like an alarm that any additional procedure, like another biopsy and another vitrification, may certainly cause some kind of viability issues in the embryos. One more from 2024, Yang et al. It's a Chinese one. And this I have included because they have got a huge number of FET cycles. The sample size was quite good. And vitrification was done due to medical personal reasons or rebiopsy. So every thing what we wanted to discuss, everything was put into a paper. So double versus single vitrification. There was a reduction in live birth rate, there was an increase in the miscarriage rates, but neonatal outcomes did not have been affected. And there was a reduced clinical pregnancy rate as well as live birth rates and increased miscarriage rates again, double versus single biopsy. So here again, we can say the additional biopsy probably is causing the damage. The neonatal malformations or mean birth weight are not affected. So the reviews are just reassuring the findings, whatever has been reported in the previous years. That's what I was thinking. This is the latest 2025 published in JARG from Italy. So they have considered 1,027 papers. We ended with 22 reports finally. So the survival rates, clinical pregnancy rates, miscarriage and live birth rates have been compared. And 13 of the 22 papers on double vitrification, that is revitrification, no effect on clinical they found no effect on clinical outcomes. But some of the studies still be thinking there is an impact on survival and clinical outcomes. And a couple of them were saying no impact on rebiopsy included. That is completely contradicting from these reviews. There was a reduction in the live birth rate in blastocysts undergoing double vitrification and rebiopsy. So, which is suggesting repeated manipulations in the laboratory can impair the competency of the embryos. And any double cryopreservation, double vitrification and rebiopsy should be limited to selected cases. So that is like, again, consistent, they are insisting on this point in every report. This is the last paper I wanted to show you. This is quite interesting. It was a triple biopsy and a double vitrification. What was the result? It was a very first case report from 2015 from Italy. They had a couple coming to them with a family history of beta thalassemia. And they had done a polar body biopsy, eggs being cryopreserved, means vitrified. There was meiotic crossing over and there was no information found from the polar body biopsy. Eggs being warmed, culture to day 3 embryos and blastoma biopsy was also performed, which ended up with the inconclusive results from the genetic laboratory. Embryo has been further cultured on that cycle. There was a blastocyst formed on day 7, and they have biopsied, vitrified, transferred the euploid embryo later on a frozen embryo transfer cycle. You can see the picture. They had all 3 done with 2 vitrifications. So this is one of the reports from 2015 where they had been just get on going with these manipulations for an embryo. Still, it ended up with a healthy baby. They were suggesting harmlessness of all these procedures if carefully performed in the laboratory. So coming to the discussion, so now we have gone through a lot of reports. What is causing the damage or higher damage between biopsy and vitrification in case if this combination we are talking about? So as such, any additional intervention can damage the embryos. But biopsied and rebiopsied blastocysts are severely impacted by the biopsy procedure itself, we all know, because in the first cycle, we are removing some of the cells. Again, we are making holes and removing cells. It's highly invasive. Is it just causing the damage, or is it the hole in the zona pellucida we are making with the laser shots at the time of biopsy? So what about the exchange of the ions, like solutes and the water between the cryoprotectant as well as from the embryo or cell as such during the cryopreservation as vitrification? So this is a question. So Taylor et al. In his study, he was just beautifully explaining that what could be causing more damage was, he was trying to see like the vitrification in that process. Sometimes you have freezing hatching or hatched blastocysts already. The zona is already having a hole. It's a common practice. So this may be very similar to the ones we are biopsying. An artificial collapse of the blastocyst with laser results in a similarly sized hole. So there also like we are getting better vitrification outcomes. So possibly the poor results are from by repeated biopsy. This is what they've been finding, rather than the direct exposure to the cryoprotectant with the pole. So it could be the biopsy, not the revitrification. Probably it's having a minimal negative effect. So coming to the summary, so we know there's been a constant improvement, there is tremendous improvement observed with advent of vitrification in the cryopreservation of oocytes and embryos. Revitrification, with all the reports we have gone through, has shown a good survival rate. In some of the reports, they have even claimed 100% survival with revitrification for every embryo, not even a single embryo lost any cell, either it's a day 3 or a day 5. But there may be a small negative impact, and it could reduce the viability to a certain extent, So talking about the clinical pregnancy rate, implantation rate, and live birth rates, where like in many of the reviews for the neonatal outcomes, they have been consistently reported as comparable with other methods. So the safety of the cryopreservation in terms of vitrification and revitrification for both the woman and the child, it necessitates further and long-term follow-up. So some evidences talk about this modifications in the epigenetic marks. Is it related to vitrification? And these epigenetic marks are very important for the oocyte competencies. Only when you have a competent oocyte, you can think about a healthy baby. So however, it's not much studied yet. We need more knowledge on the impact of cryoprotectants and the procedures as such on epigenetic mechanisms to be coming out. So until then, we have to really make a cautious decision in the laboratory and in the clinic for any revitrification or rebiopsy, particularly revitrification, because that is the topic today, is mandatory. This is the end of my presentation, and I would like to thank everyone for the patient listening. Thank you so much.
Thank you so much, Sharguna, for a wonderful talk. Over to you, chairpersons. So with this, thank you so much. A heartfelt thanks to both our speakers and to our chairpersons for setting up the perfect scientific rhythm for today's session. And before we move ahead, I would like to briefly share the idea behind starting ACE Open Forum. This Open Forum is a new ACE initiative created to encourage open, real-time, and inclusive discussion. Here, anyone from the audience may raise a hand and ask a question. You may also type your questions in the chat box. Suggestion, different viewpoints, and shared experiences are most welcome. The intention is very simple: to build a culture where every embryologist or clinician feels empowered to speak, to ask questions, and to learn. With that spirit, let me now introduce our moderator for this open forum. Okay, I need to share my screen. Just a minute. So all the questions answers we'll be taking in this forum. And it is my privilege to introduce the first moderator to this forum, Dr. Sonal Vaidya. She is a very known name in the fraternity, first Indian to be ISHRA certified senior embryologist way back in 2013, recipient of SR Mayor Embryology Excellence Award, working as a chief embryologist at Ruby Hall Clinic, Pune. And with more than 22 years of experience, she has contributed immensely to the embryology training, national workshop, live protocol demonstration, textbook chapters, and so much more to in her credit. And our next speaker is next moderator is Dr. Pankaj Kankade, founder and CEO of Reprohelix Lab, Kolhapur, Maharashtra, Scientific Laboratory Director, Orchid Fertility, Kolhapur, a dynamic researcher, educator, and embryologist with sustained contribution to the reproductive biology. So moderators, over to you.
Thank you, Dr. Manisha, and thank you, Ace, for coming up with such a brilliant topic. And I'm sure our audience have a lot of questions. But the chat box questions will be taken up by Dr. Pankaj. In the meantime, while they're being accumulated, I would like to ask the expert speakers about their own experiences about revitrification. Now, coming back to Dr. Sarguna Devi ma'am, you have presented a very beautiful paper about in your presentation about the triple biopsy and double vitrification. So, and I could, make out that a healthy baby was born out of it. So, actually, my first question was whether the PGTA results would be affected because of double vitrification, revitrification. What is your take on it?
I have to share my own experience. The numbers are not great. So sometimes we have frozen embryos and we have to make a decision on PGT depending on the results from the previous cycles. And we went ahead with the biopsy and revitrification and transfers. So with whatever numbers I have, with a single biopsy, single vitrification, and the double vitrification with the biopsy, they are comparable. They're very, very similar. And in terms of like how the embryos are distributed, it's not showing higher number of aneuploid in the embryos. That's what I have seen. It's very similar to the normal biopsy patients. This is about PGT and revitrification from my experience.
Okay, and this
I hope
question
it's not affecting much so far.
But here I would like to ask one question. Sharguna, what was your experience with the grading of those blastocysts? All of them were good graded. What was your experience with the poor graded blastocysts?
We hardly do any poor quality blastocysts because the patients are coming up with only few numbers for biopsy. There's been just frozen. So, but I have done good quality embryos and moderate quality embryos, not poor quality embryos. So even with the moderate quality like AB, BB combinations, we do get very similar kind of results. Sometimes BB has a euploid and other one has a low mosaic kind of things, but it's just a couple of patients. I may not be just saying it's a big number. We do have surprises at times. Yeah, so that happens.
Yeah, totally.
Okay, now my next question is to the both speakers. We know that during vitrification, especially after biopsy, we happen to re-vitrify the embryos immediately after biopsy because of the collapse of the blastocyst. And what is your take? Do you wait for the re-vitrification or double vitrification? Would you wait for selection of the embryo blastocyst? Would you wait for its expansion and then re-vitrify? And if you prefer to wait, would you wait for day 6, day 7? What is your protocol?
The embryos are in our laboratory. They are biopsied and immediately vitrify them. I do that. So I load onto the vitrification means ES solution, and then I go for loading for tubing. This is how I do. And anything shorter is better. That's what I believe. And then in practice, it is just helping. And some of the papers are supporting them as well. I don't leave it longer because they have been expanded and then they're already, because the lab protocol as such, even without, like for non-biopsy normal patients, just we fix the time and then we see the expansion and the grades and freeze, thaw them and transfer. So that's giving very good results. So I follow the same with this embryo. I don't give them much longer. But when we thaw them and transfer, obviously it's 2 to 3 hours before it gets into the re-expansion.
Dr. Sandeep, what is your experience?
Yeah, I mean, I would share my same feelings as Dr. Sharguna has actually said. I mean, for freezing or vitrification, we don't wait much. It's only that, what do I say? What the lab allows us to do. I mean, we generally don't wait too much, but yeah, I would wait for expansion before transfer.
So I have a question for Dr. Sandeep, and to any of the embryologists here. So I always thought like, because this is the hole we are making with the laser shots for the biopsy embryos. Do you make any changes in the time it's getting exposed to the ES solution?
Not really. I mean, there's no difference.
Is it going to be shorter, or do you think like the change is quicker because you have a hole, and you make it lesser, or it's a normal exposure on the
Firstly,
ES?
it is not a hole; it's an entire slit. So what generally happens, it's like a ball. So when you slit it open, the laser, it actually opens like this, and then it closes back. It is not a single punctate hole. So even if once the laser goes through, you have to pull the tissue out, and once the once the biopsy is done, and if the entire tissue has gone back into the zona, generally the slit would actually collapse. So even if there is technically there is a opening, But zona being as sticky as it is, it would generally stick sealed by itself, unless there is some tissue in between. So personally, I don't think there's much of change with a hole or without a hole.
When we load in the VS, we can even see the, like,
Yeah, I mean, that is the
sometimes it's
better way. I mean,
breaking.
I don't
Yeah.
want to dwell into that, but with seniority, you would realize, it is not really the time which is written on the piece of paper which matters. It is what your eyes see before you change the solutions.
Yeah. Thank you.
So, Dr. Pankaj, would you like to
Yeah.
go ahead with?
Yeah.
Yeah.
Sure. Okay, first of all, I like to congratulate Sandeep sir and Sarguna madam. Actually, they have given an excellent, perfect teaching what we all needed today. Even sir started with very basic till clinical points were added. Even Sarguna Devi madam had added all the latest papers. Even she told about the third biopsy, which I was very new to that point. So I thank you for that. So before that, I have one question. Then I'll go to the chat box. Then we have one short audience poll questions. So we'll go into that. So this is very hazy question actually, to addition to all your whatever you have discussed. In your practice, when you do a revitrification or whatever cases you would have done, so what was your frequency of getting a euploid or aneuploid, or there were much of aneuploid embryos from your revitrification? It's just a hazy question. Just I would like to understand that question.
I mean, I don't think there's much of a difference between the initial and the second lot. I mean, the only factor which matters is when you actually go in for biopsy, you would possibly choose the better looking ones first.
Right.
So technically speaking, I mean, as a broader protocol, those might have a slightly higher chance of having euploidy. But I don't think it really matters.
Okay.
I don't think my experience is significant enough to write a diktat on it, but this is my assumption.
Yeah, obviously, the revitrification might be quite less.
Pankaj, can I make a point?
Yeah,
With my experience, I can say the amount of like ploid divisions, euploid, aneuploid, and this, like, just 1 in 3 possibly, because I have had a discussion with the genetic lab and why always I'm getting on an average it's 1 in 3 and sometimes it's 1 in 5, less number of euploid. And this is what I'm just facing in the lab right now. For the past 2 years, I would say at least. Yeah.
I'd like to make a point here.
Yes, sir.
See, I feel that it's very important to mention this, that I'm seeing that the discussion is drifting towards the fact that revitrification is only done with the requirement of a biopsy, which is not true.
Not true.
A lot of the times you will tend to revitrify embryos unexpectedly because the patient has conceived, say, probably has already had one child through IVF, and suddenly discovers that now 2 embryos are frozen together, right? And then she comes and says that I have one child and now I want a single embryo transfer. So those are cases where you will say that, okay, we will thaw both embryos, but depending on the survival of the second embryo, we can give you an option of revitrification. So let's not be too fixed with the idea of only biopsy and hence revitrification. This is common in Indian labs where people tend to freeze 2 embryos together and 3 embryos together very commonly. Hardly there are labs who will freeze embryos only individually. And so many a time, I don't know about practice in your centers or states, at least in our center now, 90% of patients, they go through single embryo transfer. And so if we ever, because of whatever funny reasons, if we do end up freezing 2 embryos together, half the times we are requested by patients to only transfer 1 embryo and revitrify the other one. So these are cases where there is no question of biopsy, but still we are getting requests of revitrification. So there we have to counsel them depending on the morphology of the embryo, the pre-freeze morphology, about the chances of damage and the probability of freezing. Secondly, what I was getting at was with respect to biopsy, the discussion that you guys are having. Generally, we will think of biopsying frozen embryos only in the event of 2 or 3 FETs failing, the first 2 or 3 embryos failing. That's when the clinician starts panicking, the patient starts panicking, especially when multiple embryos have been frozen. And then, so these are all cases of RIF, where you start wondering that, okay, is it now wise to thaw the remaining embryos, check for ploidy, because with seemingly good blastocysts, you've not had a success in the first cycle or the second cycle. Because otherwise, because if a prospective decision has been taken for a PGTA cycle, then you will probably never freeze embryos and then perform a biopsy and a revit. You will prospectively do a biopsy and then freeze the embryos. So here, let's be very clear that we will only end up doing a, a, a revit in case of a biopsy later on frozen embryos if there is a scenario of repeated implantation failure. And so with repeated implantation failure, you can get anything. There is a very high possibility in case there is a associated advanced maternal age that all embryos may be abnormal. There is no set formula. You cannot say that what is the percentage of embryos you are expecting because the aneuploidy is not determined by the fact that you are doing a biopsy on frozen embryos or you're doing a revit. It depends on the patient profile, whether the patient is an advanced maternal age patient or has a history of multiple miscarriages or just by the virtue of RIF. So I hope that, you can make this distinction. Thanks.
Yes.
Yeah,
Rajiv,
so
I have
just
some.
to add on, so I think Gaurav, Dr. Sandeep actually started with quite a horrible story because when he talked about medical cases and the lab cases where vitrification, where a patient was coming for embryo transfer and had an accident, and therefore the embryos needed to be revitrified. So these are the cases where
Yeah,
we are
this
not
is
just
also a
talking of
great example.
biopsy.
Yeah. We
I
often
mean,
get
he's
this, when
experienced it.
last moment the patient calls and says,
They
I have
can't come.
fever. I have very high grade
Exactly.
fever.
So
And I
that's what
cannot get
he's
a or there's a death in the family. I cannot come.
correct.
And we need to
So,
revitrify.
so
So
these
there are
are
times
the
when,
cases. So he's listed
suddenly,
out many of them,
there are suddenly,
but
when you
yeah,
can't transfer at times, there's suddenly, there's a false passage which is created in the cervix.
yeah.
Was
There's so
about to
many
come.
times. Yeah, so that is the main cause of revitrification in my practice. Thawing for biopsy and revitrifying actually is only about 20 to 25%, if I'm not wrong.
In our practice, it is
but
5%.
Okay.
Yeah.
so
That's
my thing is that all the literature. So point is like the cases that you said, Gaurav, that people have already had a baby and you have 2 embryos on one device and you're going to use one. In most cases, the second one will rarely be used. I mean, we are not sure because the second one may also lead to a pregnancy. So we don't really know the outcome of the revitrification in these cases. Of course, it may not lead to, but most of the literature, I mean, that triple biopsy one seems very heartening that it is also possible. But on the other hand, all the literature seem to say that the pregnancy rates are low, miscarriage rates are high. So I think
Yeah.
the message should be that we should not go for multiple embryos on the same device. I think we need to give a message of what's the optimal you want to put on a device. Is it two or more? Because the message is that revitrification does give us, let me put many more and then always revitrify. So I think that would be something which would be nice to have a clear cut guidance for the because this question I think is bothering, because right at 7 itself, within 5 minutes we nearly had a full house. So people are looking for answers on what to do.
So
So
I'll tell
maybe,
you,
yeah.
Dr. Rajvi, we revitrify a lot in our practice. And typically in our practice, if there are multiple blastocysts, then we make sure that we freeze at least 2 to 3 embryos individually as single blastocysts. And then after 3 individual embryos, we start freezing them in pairs. So I'll tell you the thought process behind this policy is that we want to give the patient at least 2 or 3 trials with single blastocysts. This is in order to minimize the chances of multiple pregnancies, and it obviously brings it down drastically. But for a patient who is not able to conceive after 3 failed transfers, then we think that it is time to give that boost of the second embryo, not to aim for a twin, but to increase the chance of one of them implanting. But surprisingly, what happens is when patients, they are going through this journey of first FET and failure, and then coming to the second FET, and if unfortunately they have another failure or a third failure, you will not imagine, it is so incredible that when the time comes for these patients to transfer embryos, where 2 embryos have been frozen, they will automatically come and request for only 1 embryo to be transferred, because they understand the basic game of IVF, that it is not the number of embryos which is determining pregnancy, but the number of times or the number of opportunities of embryo transfer that can be derived from a single egg pickup, which will, so they understand that the cumulative chance of getting pregnant increases not with the number of embryos, but with the number of embryo transfers or attempts. So this is a natural instinct where they think, oh my god, I don't want to use up my embryos. So if I have 2 embryos, I'd rather have 2 more attempts,
I think,
because it's the
Gaurav, we are
endometrium
actually
and there are so
planning
many
a
other
discussion.
extrinsic factors.
Yes, yes. So
I think
Just
we are
just
now
no
heading
time.
for another
So
discussion on multiple embryo transfer.
yeah.
And maybe, Manisha, that's your next topic.
Right, ma'am. I was
Because it's
thinking
very
that because
interesting.
it is again a very debatable topic whether multiple single embryo or double
So,
embryo will increase your
that
chances
can
of
be.
pregnancy.
I just want
so
to ask both the speakers. The lectures were really very informative. I just want to ask both of you that how should patient be counseled about potential benefits and risks of
actually, Harsha ma'am, we have
Yes,
one
of course.
question in
Yeah.
Harsha ma'am, we have the same question in our poll also. We'll just wind up with the audience questions, and after on
Yes.
we'll go in. The same
Please
question is
do
added there
take
also.
them. Please
Yeah.
do take
Do you want to take up some of the audience questions? I think we're
Yes, yes,
waiting for
ma'am.
Yes,
it.
yes.
that's
We
what.
have 2 questions clubbed, Dr. Sindhuja and Mrunal, but they have the same type of question. Actually, we have already discussed. There are a lot of evidences now to wait for re-expansion, and if it is an expanded blastocyst, even after biopsy, some evidence suggests to freeze within 30 minutes before re-expansion. What is your opinion on that?
So I have explained already. My experience
Yeah.
is always like finish the biopsy, and by the time you are just taking cells out of it, it'll shrink, and I immediately go for vitrification, because again after thawing it is going to go through again or a transformation of this solutions between in and out of the membrane. So I don't want to really subject them weight or whatever. But my colleagues in the UK, back in the UK, they just do the biopsy and leave the embryos back into the culture trough, and they do every other job. Later, they go for freezing the embryos. That I have seen certain numbers we had done like that, because when they started that, I was just out. So there as well, like we were not having any big issues. But currently, what I practice is only that much. So I'm not having any experience about like leaving them longer after vitrification.
Dr. Karunakaran or Dr. Gaurav, any of you would like to comment something about it?
I would like to add one more point to the previous discussion, like about the growth, like revitrification in non-biopsied embryos. For patients, sometimes you may have to freeze them early, day 3 or day 4, and may have to have a grow out and do. And anything is always having a proper customized discussion with the clinician, with the team. Even we freeze the embryos accordingly, whether it's single or double or whatever, so that we do not waste or go for revitrification. So in general, the revitrification, the amount of revitrification what we do in the laboratory is very, very minimal. And I think Gaurav's counseling is really great that patients are going for single embryo transfers. And not many of the patients are agreeing for single embryo transfers, or not many of the laboratories or clinicians are agreeing for that. So we may have to really see our own data, what number is giving you the best results, but not into multiple pregnancies, then we have to customize that way. So this is a different scenario like we have. And patients are not coming more than 2 frozen embryo transfer cycles to us nowadays. Like they look for a different place, and
Yeah, so
any biopsy is done only for the indicated patients.
for that counseling has to be very strong for patients to come back and stick to your center. So that's one thing which is required. Immense amount of counseling goes in. For Manisha, the question that you asked,
Yeah.
um, I completely agree with what Devi is saying. The whole idea behind vitrification is successful vitrification is to first getting rid of the water inside the blastocyst
Absolutely.
before we vitrify it. So post biopsy is actually the best time because the embryo is completely collapsed, it is completely devoid of the blastocele fluid. And so, even in our practice, the moment the biopsy is over, immediately it is taken up for vitrification. Not a second is wasted. And I just wonder why, other than workflow issues, why would you let the blastocyst re-expand?
Dr. Gaurav,
Because
some people believe that blastocyst has already been traumatized, so give it enough time because I have attended such lectures as well. So that's why I specifically asked this question.
you can take it from me,
Yeah,
a very busy PGTA center where we see absolutely amazing, survival rates as well as implantation potential. And these are all embryos which are immediately vitrified. And our main concern is to not let the blastocyst re-expand because then how will you get rid of that fluid inside? You know?
very logical.
Yeah.
Very
As Gaurav says, the water is already out when you are taking the embryos after biopsy. So why do we need to really just refill the water and then
Yeah.
dissolve it at the
Yeah.
time?
absolutely very logical.
Okay,
Also, when you're doing
actually,
it for medical reasons, like the case Dr. Sandeep said, would you wait for re-expansion? You got the news that you're not going to transfer. So at what stage during the warming, you finish the warming, would you wait for complete re-expansion or in between you'll start the revitrification? Is there something like an so-called optimal time in this not optimal situation?
If it is not a biopsied embryo,
Mhm.
We
then
are
I
just
would,
talking of normal embryo,
yeah. So if it is not a biopsied embryo, then I would wait for the first hint of life before
Okay.
vitrification. If it's a biopsied embryo, it is best to be to start the process immediately.
Immediately.
so actually we are running out of time, so we'll directly move on to the poll. So is my screen visible now?
Not yet, sir.
Now?
Yeah.
Yeah.
Actually, can you just scan this code?
Yeah.
There are a couple of questions in the chat box. So you
Yeah.
could also quickly go over them.
Till time, you can ask any question from the chat box also. You can go on that also. I'll take
How
another
do
1 minute.
we-
So Aneet Vaishya from audience, he wanted to know, so which size of denupoid you will prefer for the hatch blast or for hatching blast?
300.
Hello.
300 micrometers.
300 micron, the same. What is the ideal laser dosages when performing the biopsy? And what is better, single shot or multiple shot? So is it about a biopsy or rebiopsy? Anyway, they have written biopsy.
Yeah, laser shots, I just go with not single, means it's depending on the size. If you're giving a large shot, it is just one. It's having a smaller shot, you need more. It's practical. And as long as you open the zona at one spot, it's more than enough. Not to go too much. That's it.
Very precise, thank you. And Mr. Suresh Dhumal wanted to know, is there any effect of multiple shots of laser during biopsy on the embryo? I'm not sure whether they wanted to know about biopsy or rebiopsy. So both the scenarios.
Probably it's biopsy. Yeah, multiple shots at the for opening of laser with the small shots, or sometimes to cut it off. We just give just couple of shots and then just flip off.
No, the question is about excising the trophectoderm. How many shots should one take?
That's what I have told her in the previous.
So can we just move to the poll? We have total 14 participants. Okay, 15 have been joined now. So we'll start one by one. Okay, so the first question, it is a general poll. It is for all of everybody, and you can comment on the same also. So at which stage do you feel revitrification is safest? Cleavage stage embryo, early blastocyst, the expanded blastocyst, or none? It should be avoided at all stages. Okay, two
We
people
have
have
an
voted.
option all, above all, no. Okay.
Okay.
I know, I can't choose actually between this.
By the time we are waiting for the result, what should be the stand of embryologist on doing the biopsy for RPL? That is something, considering revitrification, rebiopsy can cause increased miscarriages. That is interesting. Dhanya Bijoy wanted to know the answer.
What is the question?
What should be the stand of embryologist on doing a biopsy for RPL, considering revitrification, rebiopsy can cause increased miscarriages?
No, so don't do a rebiopsy. Do it prospectively.
Just one, yeah.
Perfect.
Okay. So many have given for expanded blastocyst. We'll move to the next question. So how often does revitrification happen in your center? Less than 1% of cases, 1 to 5%, 5 to 10%, or more than 10%?
Okay, there's another question in the chat box, which is also very interesting, by Vaibhav Kukani. How long would you keep a completely collapsed embryo post-biopsy in the ES? Does it's already collapsed?
It's less than 9 minutes I keep. But with the coming up shorter protocols, we may be just doing just 2 minutes freeze in the future. I make it less.
So here revitrification happens very less at those who are attending this poll. Okay, I'll go to the next question. So would you revitrify a euploid PGTA blastocyst if required due to cycle cancellation? Yes, without hesitation. Yes, but only with excellent morphology, only after detailed counseling, or no, I prefer not to revitrify euploid embryos.
Somebody texted, can't see the pool.
They would have they have to scan this. I think 1 minute, and I'll share this.
QR code, yeah.
You have to scan this QR code. 1 second. Okay, that QR code is not visible right now. It has to take previously only. So it's
very
50-50.
Very
Yes, without
interesting
hesitation, and only after detailed counseling. Okay, so we'll move to the next question. What do you think, if is there a major risk of revitrification? It reduces implantation potential, or there is a zona hardening or delayed hatching, or there might be increased cellular apoptosis, or no major risk is done correctly, if done correctly. Okay. Oh.
That's nice.
So yes, many people are telling no major risk if it is done correctly. Now the next question, in the same, Harshaben, what you are asking, in counseling patient, how do you describe outcomes after revitrification? It is equivalent to single vitrification, a slightly lower success but acceptable. We don't have enough evidence, or we discourage it unless medically required. Okay, our audience says slightly lower success but acceptable. Okay, we'll move to the next question. Which embryo grading parameter is most likely to predict successful survival after revitrification? The ICM quality, the trophectoderm quality, or expansion grade, all are equally predictive.
Excellent. Unified here. Yes.
Yeah.
Very brilliant questions. Yeah.
Okay, the next one, if you had a choice, what would you prefer to avoid in double vitrified embryos? The second biopsy, or a prolonged manipulation time, or a poor quality blastocyst, or a de-vitrification, revitrification more than 30 minutes? Okay. Okay, many of the people have voted for poor quality blastocyst. We'll move to the next. Does revitrification, this was my question, does revitrification impact PGTA results? That is anucleatic called accuracy. Yes, can increase mosaicism artifacts, or yes, can increase DNA degradation. No major impact, or not sure, no strong data. Okay, it is 50-50 for all. Okay, the major answer was given for yes, can increase DNA degradation. The next one, in your experience, how do outcomes, implantation or live birth rates after revitrification compared to single vitrification? Almost the same, slightly lower, or slightly significantly lower, or not sure, insufficient data in our center.
How will you determine that poor implantation is because of revitrification or because of something else? There may be so many co-founding factors.
Yes. Actually, the first question was how many centers are practicing revitrification. The number was previously given. Na? So accordingly, this audience are putting the numbers. So it is just a general question for this thing. Okay. So many people are taking slightly lower according to their experience. So what is your threshold for considering an embryo fit for revitrification? So it's only grade 1 embryos or grade 1-2 embryos? Any embryo with more than 50% viable cell mass or morphology should not determine the decision.
That was my question.
Okay. Anything like a normal freeze, revitrification also go with that, right?
Okay, so grade 1-2 embryos was the answer given. Now the next one, what is the most important clinical factor when deciding to revitrify? It's a patient age, euploid versus non-euploid status, number of remaining embryos, or it should be like endometrial readiness.
Very tricky question.
Mixed of all. So tricky answers we have got. Oh.
None of them.
What is the most important?
Number of remaining embryos is given the highest rank.
Say whatever you have.
So it's a cost. If you are giving a cost to the patient for revitrification, then they are.
But it will be lower than the next cycle.
Yeah.
So that's why the answer is number of remaining embryos. The next one, which future innovation will most improve outcomes of revitrification? Actually, this question is taken from any other paper or this this thing. Rapid microfluidic warming system or improved cryoprotein chemistry, AI-based embryo pre-selection or closed vitrification devices.
Is it not the Fast and Furious you included?
No, so a rapid vitrification, first, both are similar, first and second. What improvement do you expect? A rapid system. We all are looking forward to.
Rapid microfluidic warming systems. Okay, anyway.
That is also true.
Just about rapid, please.
But people are more interested in improved cryoprotectant chemistry over here.
Shorter protocols.
So we have done with our questions, polls.
There are a few more questions in the chat box.
Yes, we can take from. Yeah.
Please, open forum is for audience. Please take all the questions quickly.
So yes, there's one question from Haswant Mohan Raj. For collapsed blastocyst, if it's transferred to ES immediately before expansion, will it expand to normal size at the completion of equilibration process?
We don't see a complete re-expansion in general with the PGT embryos.
But you do see definite change. I mean,
yeah, there are changes.
I have covered most of the questions.
Yeah. So with this, like every good seminar, every good thing, we came close to the end of this session, I believe. So am I audible?
Yes,
Yes, you are.
Yeah.
Thank you. A big thanks to all our chairpersons, our moderators, our speakers, and all and every participant who enriched today's session with questions and insights. We hope today's session has strengthened your confidence in managing revitrification decisions, both in clinic and laboratory. Our sincere thanks to ACE leadership for their constant support, our President Dr. Sujata Ramkrishnan Madam, Vice President Dr. Gaurav Majumdar, and our Secretary Dr. Parusaram Gopinath for giving us complete freedom, encouragement to organize programs that truly add value to our community. A very special and heartfelt thanks to Dr. Rajvi Mehta ma'am. This entire program was her thoughtful idea, and at every stage, her guidance, meticulous curation, and scientific wisdom shaped it into the success we witness today. A heartfelt thank to all our ACE members and every participant who joined us this evening, asked questions, contributed perspective, and made this session interactive and meaningful. ACE will continue to curate such scientific discussion on nuances, practicals, or emerging topics. Some upcoming master classes may be exclusively to the ACE members. So if you are not yet a member, this is the right time. Please scan QR code on your screen and become part of our growing society. As Dr. APJ Abdul Kalam reminded us, excellence is not a one-time act. It is a continuous process. May we carry this spirit forward in our labs, our clinics, and in our community, growing a little more every day, learning a little deeper every session, and striving together for excellence that is ongoing, collaborative, and unending. And before I close, on behalf of the entire ACE family, I would like to wish our past president, Dr. Ved sir, a very happy birthday. We truly wish you a good health, happiness, and continued inspiration for all of us. Thank you, each one to you once again, and we wish you all a wonderful and peaceful evening. Thank you for your time and support. Thanks, everyone.
Thank you.
Thank you so
Thanks,
much for
everyone.
bringing in a rare topic because revitrification is not much discussed. Thank you so much for that. Thanks.
Thank you.
Good night.
Good night.
Bye-bye. Good night. Thanks, Aguna. Thanks, the
Thanks, everyone.
moderators. Pankaj for the poll. Thank you, Sonal.
It was wonderful.
Yeah. Okay. Bye-bye. And thanks,
Bye-bye.
Dr. Sandeep. It was a good